This is part 7 in staying ahead of your behind, colorectal screening. And this is on the U.S. Preventive Services Task Force. That's and you could argue whether it's well funded or not. It's whether anything public health is well funded enough, but it is. It's far better funded than it was 40, 50 years ago. And it's a major focus of resources in terms of making recommendations, supposedly unbiased, and I think for the most part is, on an important question like colorectal screening. We've talked about this before. There are, 51,000 deaths associated with colorectal cancer each year. Over 30,000 of those deaths could be avoided with proper screening. So this is a very important subject. What does the U.S. Preventive Services Task Force have to say? Well, the first thing they say is you should get your screening. And they talk about age components there. We'll go over that in a few minutes. But here's the thing. I'm going to go into a little bit of the frustration that a lot of people will feel if you study the U.S. Preventive Services Task Force guidelines. There are a lot of options. In fact, 7 different options that they discuss. And they do go on to review the literature fairly extensively. But then they back away from saying use this technique or this technique, use FOBT or sigmoid or fecal DNA or colonoscopy alone. They continue to dance back and forth in this area of do they make a specific recommendation or not? It turns out that they've got a fairly good reason for doing this, and I'll cover that. I'm going to leave you in suspense on that for those of you that would be put in suspense. But first, a brief introduction. It's Ford Brewer, F-O-R-D, Brewer, B-R-E-W-E-R. This is the prevention channel, and we're focused on helping you prevent the things that kill and disable you, like heart attack, stroke, dementia, and cancer. So again, this is a series on colorectal cancer screening. So again, the U.S. Preventive Services Task Force. Basically what they say is there's level A evidence. Adults age 50 to 75 should get screening for colorectal cancer. Then they go down to level C and they say, well, if you're 75 to 85, maybe you should get it, maybe not. Part of the point is that these cancers are relatively slow growing. So if you have, and they go on to say, if you have any significant other risk for death, like cardiovascular disease, you should consider whether or not the patient will be alive long enough to actually benefit from going through colon surgery if you have cancer. Now, in the intro, we talked about the fact that even though they go into one of the most extensive literature reviews, and maybe expensive as well, regarding colorectal cancer screening, and they list all of the topics, they sort of bounce back and forth in terms of saying what they recommend and what they don't. So there's a great article on this. It's an editorial which is linked. These were published in JAMA, by the way, and I'll give you a link below the video. Clinical Practice Guidelines for Colorectal Cancer Screening, the new recommendations. These were as of 2016, and they do cover the blood test as well as the fecal DNA test. This editorial is by David Ransohoff and Harold Sachs. Basically, for 32 years, the U.S. Preventive Services Task Force has served the nation with analyses that are scientific, transparent, and untainted by conflicts of interest or political influence. And again, I think for the most part that's true. It's a great resource. But as you see here, we've got lots of red ink. I've underlined a lot of components that I'm going to read for you because it does deal with the issue. The 2016 guidelines strongly recommends screening for colorectal cancer. It lists 7 different strategies. The screening tests are not presented in any preferred or ranked order, and that implies that the task force does not have, that considers them to be equivalent. However, the task force presents evidence that some strategies are better than others when tested in representative populations. 4 strategies result in essentially the same life expectancy gains and consumption of healthcare resources. That would be colonoscopy, FIT, fetal immunochemical testing, sigmoidoscopy plus FIT, and CT colonography. The task force lists the FIT DNA. In other words, it's the multi-targeted, it's the DNA which includes FIT with it, but states that it's less efficient. In other words, red, way too expensive. Finally, the task force lists 2 other strategies: guaiac, fecal occult blood testing. Again, that's the old testing that's been around for many decades, and sigmoid alone, but cites evidence indicating that they are, although effective, they're inferior to other listed strategies. So again, you get some clear recommendations from them. One of them is the fecal DNA is very expensive. Fecal occult blood testing alone, that's what we used to do a long time ago. That's not the best. Sigmoid alone, again, not the best. But sigmoid in addition to FIT testing, clearly very good. So the PSTF, the Preventive Services Task Force, it appears to be saying that some tests are better than others, but then does not specify a preference. How can tests be different but yet the same? So here's the thing. They go on to acknowledge this paradox and make the point: the best screening test is the one that gets used or performed. So the point behind all of this is, and they go on to acknowledge it later. I'm not going to get too much deeper in terms of the details around this debate. The task force, and by the way, when I was running the postgraduate program at Hopkins on prevention, the residents formed the U.S. Preventive Services Task Force was formed within the federal government, and my residents at Hopkins actually wrote the first set of these literature review guidelines for the very first convention of the Preventive Services Task Force. I can tell you they get complicated. And they've mushroomed in complications since then. But back to this point, the U.S. Preventive Services Task Force has to deal with more than just science. And this is one of the things that irritates patients about me. There are several topics, for example, TMAO and what's not known about that. And people will say, well, either tell me not to do it, or just give me the science. I will give you the science, but you're the patient. You have to make the decision. And that's what the U.S. Preventive Services Task Force is saying in large to the U.S. population. Get with your doctor, understand the pros and cons. We've given you the evidence around them. There are 2 or 3 that we would not recommend. We would not recommend fecal occult blood testing alone. They make it pretty clear that they're not a big fan of the fecal DNA because of cost, and they wouldn't recommend sigmoid alone. But the others do make sense. Thank you for your interest.